characterize for you exactly what percentage. In our experience, it's probably only between 5 and 10%, but it's a very small number compared to the overall number. The secondary question about calcaneal valgus, I don't know that I have a consistently good way to treat that once it develops. I've seen it a lot in the children where we've crossed the ankle and where the fibula has persisted in having a pseudoarthrosis, and that to me has been the population. So a key feature of that is trying to resolve the fibular pseudoarthrosis and then correct the deformity secondarily. Growth modulation if possible, but if it's a mature child, I don't have a consistently good way to manage that because of the fear that I've had that if I create an osteotomy, that it's not going to heal. And perhaps you have some other experiences, or Benjamin, I see you back there. Do you have some experiences or knowledge about good ways to manage the calcaneal valgus that can be seen?
The calcaneus really often occurs when you treat them late.
Yeah.
The valgus is a different issue.
Yeah.
And I think valgus is related to the fact that you go to persistent fibular pseudoarthrosis. So I must admit that I have not been tackling the fibula at all. And contrary to many reports, our union rate is as good as theirs.
Yeah.
So there are many factors which we don't know, we don't understand fully. But as far as calcaneus is concerned, it's usually in the late treatment if you persist with non-union for a long time.
I would agree. So I don't know if that gets to the question. Do you have other strategies that you've tried?
I stretch it out with the Lizarov, basically. But I must agree that it's not a very good solution either because it recurs. So even I don't know how to tackle that deformity effectively.
No, I would agree with that.
Thank you.
Thank you.
We'll close this session. Just one announcement. All of you have got the evaluation forms. We would like you to fill it up and pass it on to us before you get your certificates. So we want you to give the forms. And please don't worry about taking notes all the time. We will try to send you the CDs of all that is going on. Okay? So.
Back in what, 15 minutes?
Sorry? Yeah, we're back in 10 minutes, possible. Yeah. Once again for his presentation on physeal injuries.
This is really going to be management of not the acute fracture, but give you some background on how you deal with those rare instances in which we have a growth arrest. Now, what about the classifications? Are they helpful? Dr. Ogden has a classification, very extensive, and I doubt if it's just so complicated. There's another one, it's in Peterson. It's not much different from the soft, but when you read it now, is this new textbook
each of those guys who had the cases, since they knew everything about it, they should have seen to it that they sat with the respective expert. Gave him the history, gave him the
cases hadn't come. And he has a classification. His probably has a little bit better prognosis.
Prepared us something. Even if the child doesn't turn up, we knew about it. They could have written it.
That's
Anyhow.
I was here 2 weeks back.
And
I told Cindy, please arrange that because we need the cases. That's important. I told him the
that
list.
could have been better. I pulled up both those chaps already.
No. Where's home?
Lights come.
Home that everybody likes and has really stood the test of time. It's not prognostic, it's descriptive. Originally they thought it would be
It's all words, so they all
Saltbearers 4 and
impromptu
Saltbearers
show.
1 would be
But
less
that's not the way to
of a problem. Now, I think the major contribution of Peterson is he talks about his Peterson type 1, and if you have a diaphyseal fracture that goes up to the physis, you need to follow those. This girl here looked like just a simple diaphyseal fracture, and she came back 19 months, and you see she has a growth arrest. Now, let's look at the anatomy. The blood supply to the growing cells is on the epiphyseal side, and that's where the growth is. That's where the blood supply comes in. Then those cells grow and maturate, and they actually outgrow their blood supply. And when they do, the matrix calcifies, does not ossifies, and those cells die, and then their new cells come in. They're brought in by blood vessels on the metaphyseal side, and they bring in the osteoblasts, osteoclasts that take up the dead cartilage, and the osteoblasts. Now, the blood supply here is on the epiphyseal side, so you want to avoid that area. That's the dangerous side. If you injure the blood supply, you can get death of those growing cells and ischemia, and you get a growth arrest. On the safe side, you can do just about anything as long as you don't go up to the growth cells. And you can take that out. If you take it out, all you do is you just disrupt the reabsorption process, which will eventually come back. So you get a tongue of cartilage that is not converted to, or replaced by bone on somewhat of a delay. Some of the physes are very vulnerable to injury. Some of them, the physis sticks up kind of like a mammary process. So if you have a shear force across that, you can getting injured into the growth cells, as you can see here. The growth, and this is typical in the distal femur because that's one that has to have a lot of stability for tension and stress fractures. Normally, it was thought if you do this under controlled conditions in the lab animals, most of the time the fracture line will go through the weak area or the zone of hypertrophy. But in the clinical situation, that's not always the case. This is an example from a man that took a physician that took a biopsy of some ankle fractures, and you can see that there the physeal line or the fracture line went through the resting cells. Now, the basic pathology of the growth arrest is that it is sclerotic bone because it's subjected to tension, a lot of tension forces, and so the bone reacts. And you get cortical bone. Normally there's cancellous bone on either side of the physeal plate, but if you have a bony bridge that develops there, the cells will continue to try to grow on either side of the bridge, and they'll put a lot of tension in it, and the body will react by putting down a lot of cortical bone. That's important. That's what you want to look for. Your bridge is composed of cortical bone. Now, there's different patterns of arrest, and everyone's got a little different name for them, but they're all the same. There's three major patterns, and the best way to remember them is don't say, well, it's a type A, type B, or type C. Is use Peterson's classification, and they're just descriptive. Is it a central bridge? Do you have asymmetrical Harris-Park growth migration away from it? If it's a central bridge, you can see that it's in the center of the thing, but it's completely surrounded by normal physeal cartilage. The peripheral physis remains intact. If it's a central, it's kind of like a volcano. That bridge, as it grows, the distal portion of the physis grows away from it, and that bridge stays up into the metaphysis and provides kind of like a volcano, and the physeal plate actually goes vertical, becomes vertical. And that's important when you're looking for the physeal plate. You have to realize that it's physeal. So it's kind of like a central volcano effect. Now, the peripheral bridges, of course, are very easy to get to. They're on the periphery, and you can see the bridge is on the periphery. Now, a linear bridge is usually a result of a Salter-Harris 4 type of fracture, and it goes from anterior to posterior. And again, what you have is the asymmetrical Harris-Park growth arrest lines. That's a very good biological marker to tell you how it's growing or not growing and where the bridge is. It's the best way to tell it. And it's usually associated with Salter-Harris force fractures, and it goes from anterior to posterior. Now, how do we make the diagnosis? Well, the X-ray criteria sometimes early are very difficult to see, but what you look for lack of growth of the physis, it narrows. You look for the development of sclerotic bone in there. Normally that bone is cancellous and very porous, but if you've got a bridge, as we said, it turns into cortical bone. So you look for sclerotic bone, and you have absent Harris Park migration from the area where the bridge is. And if it's asymmetrical on one side or the other, you'll begin to get angular deformity. Now, good polytomography is good. CT scans help some, but other imaging studies may be more helpful. Nowadays, the CT scans are so fine thin, so fine cuts, that it's very easy to see the bridge. MR is, of course, the gold standard, and here you can see this patient begin to show some angular deformity, narrowing of the physis, and on the MR you can see that there is definite a bridge going from the epiphysis to the metaphysis. Now, the location affects the type of deformity, the surgical approach, and the success of the resection. Now, if it's in the central, you have kind of a volcano effect. If it's in the peripheral, you usually have more severe angulation. In the central, you have mostly shortening, depends on where it is, but you don't get so much angulation. And if it's longitudinal, you'll get angulation, and depending on how close it is to the periphery will determine the degree of angulation. And you'll also get some shortening associated with it. A central bridge, you have physis on either side, and you take out the bridge, and you have viable physis that will continue to grow. So you have symmetrical growth. A peripheral bridge is easy to get to, but it has poor success rate in resection because you have a physis, you get rid of the bridge, and you don't have anything on the periphery to allow it to grow, and so your asymmetrical growth will occur once you resect it. Now, what about the results? When this started doing this, Langenskoe came with it first in Europe, Bob Bright popularized it in the United States, Ham Peterson really spent a lot of time and a lot of research on it. It was kind of his life's work. We all thought, this is the answer. We can take out that bridge and we can cure this. But there's nothing any more humbling than long-term results. And if you look at them, there are 3 big series in the literature about when it first came out. And you only got excellent results. In other words, normal growth in about a little over a third. A little bit less than a third, you'll get good results. You'll get growth, but it's not normal growth. And you may not get any growth at all, or you get very little growth in another fourth. So it's not successful in everything. The factors you want to know is what contributes to success and try to pick the ones that you think will be successful. How big is it? What's the age? How long has it been since the injury? And what is the etiology of this? 30% is kind of the kickoff. If it gets above 30%, the remaining physis is usually not strong enough to provide good growth. You may get growth, but you may not get good growth. Certainly the younger, the more you have stimulation from growth hormone and the potential for growth. So you have to have at least 2 years growth left, and I'd say even a little bit more, 3. How long has it been since the injury? If you've got that bridge in there, the physis on either side of the bridge and it's not allowing growth will begin to deteriorate. And so if it's been there for a long time, some of the cells that were viable to begin with begin to deteriorate. After 2 years, you have poor potential for growth. And what's it due to? If it's due to trauma, then it's a very specific area that's injured. But if it's due to infection or radiation, you have gradations of injury. And so some of the cells, you may get the bridge out, but the cells next to that bridge that you resected may not be viable